Hello, my name is Paul Henderson. I'm the founder and CEO of Accelerated Medical Diagnostics. Our goal is to personalize chemotherapy using a platform technology, but starting with our first test, which is called InductDx. This test is focused on our first product and cancer type of acute myeloid leukemia, which is a deadly cancer. Patients often, as soon as they are diagnosed, they have literally just a few weeks to a few months to live, and the choice of treatment is critically important for these patients. It's an aggressive blood cancer that causes white blood cells to be immaturely and overexpressed so they don't do their job of fighting infections, and they crowd out red blood cells for oxygen, so patients feel anemic, they have problems with infections, and they're quite sick by the time they finally make it to the doctor. The median age of diagnosis is 67 years old, which is important from a business perspective, meaning CMS is likely to be the first insurer. And it's a cancer that is in the top 10, certainly, but about 20,000 new cases in the US are diagnosed per year, and about half that many are going to die every year. So this is quite a deadly disease. The way it's currently treated, regardless of age, above 60 or below 60, is an important cutoff because these patients have different responses and different reactions to the chemotherapy, but they get chemotherapy. And the most common of which is called 7+3, which means 7 days of infusion in the hospital with one type of drug, and then 3 days of injections of another kind of drug. So it's called 7+3 just because of how the chemotherapy drugs are administered. And if patients then respond to this after about a month, they're apparently cancer-free by analysis of their blood and bone marrow, but because it's known that there are traces of disease left, they end up getting intensive follow-on therapy thereafter. The problem is, in patients over age 60, only about half of patients respond to the therapy, meaning only half have a complete disappearance of their cancer, and up to 30% of the patients actually die from the therapy. It's that harsh. And currently, there are different methods for looking at how well these patients are expected to do, including age, certain characteristics of their DNA, including mutation status. But these tests take weeks to perform, and the results are often obtained after treatment starts and are really only informative for what to do next if their chemotherapy doesn't work. And our goal is to develop a test that can predict quickly which patients are going to respond to the chemotherapy before the chemotherapy starts, and there are other decisions that are available to use in that precious little time that some of these patients may have left. So our goal is to take this so-called 7+3 therapy, drop it onto wells containing cells taken directly from the patient, and then do a mass spectrometry analysis that tells us the level of drug binding to DNA. Both of these drugs bind to DNA, and that's how they kill cancer cells. So the idea is the more drug DNA binding there is, the higher the likelihood that they're going to respond to therapy. And the way that we're doing this in terms of developing a test is patients come into the hospital, which currently is at UCSF and UC Davis. They take a simple standard blood draw of which we analyze the white blood cells. All those patients go on therapy, and all those patients get our analysis, and then we analyze the level of the biomarkers from each of those that are generated from each of those drugs in the patient's DNA. And the simplistic idea is using statistical analysis, we'll then develop a threshold of the biomarker levels that will be predictive of response. Thus far, we've done this in a 10-patient pilot clinical trial in which half the patients were responders and half did not respond. And just like the previous simplistic graph, this is exactly what we saw. We were able to exactly distinguish responders from non-responders. In as little as 10 patients, we've got statistically significant results. And now we're expanding this to a 100-patient clinical study. Importantly, this work can be done on frozen biobank samples, so we don't have to wait to accrue 100 fresh patient samples. I'd like to thank you very much for your time. This is our prototype. It's not ready for launch yet, but we've made great progress in figuring out just how to do this, and really we need resources and help scaling this up, getting it out the door, and helping patients as quickly as possible. Thank you for your time.